Welcome to another episode of Essence of Medicine. And today we are going to talk about the evolution of technology in musculoskeletal surgeries. Now, when you fly an airplane, you get into this massive piece of metal. You go up and down, and you don't even think twice about all the 10,000 things that has to happen for you to safely go from New York to Los Angeles. In medicine, is not different. You enter the door to a hospital, and thousands of people and hundreds of thousands associated people work together in harmony to make sure that we put you to sleep, we open your skull, we take a tumor out, or we work on next to your vessel, and you safely, in vast majority of the time, without any complication, you safely go through a procedure, and then you go home. You don't think twice about amount of the technology has to happen between these two time frames that enables you to get your life back and go through a healing process. Now, I have a very special guest today. Dr. Fennell is the orthopedic surgeon and has been working with me in Crookston for last 10 years, Colin, right?
Good afternoon. Yeah, it's been over a decade now that we've been working together in a small town in northern Minnesota.
And between two of us, we have seen a lots of technology change in medicine. Why don't you tell me a little about yourself, about what qualifies you to be an expert in this?
Oh, becoming an expert just because of getting old, I guess. You stay in the business long enough. I started practice back in 1990, and my training was back in the mid 1980s. Finished medical school in 1980. So over the last 40 years, I've seen a lot of things change and come along that have transformed how we do our business. So part of the expertise comes from just time of watching the evolution of things, but the other part comes from obviously using that same technology and watching it in my own hands and how I've been able to change how I do procedures over the years. So it's been fascinating. And the university where I trained, we actually had a summer internship with our Department of Civil Engineering. And the Dean of Civil Engineering had a co-appointment with the University Orthopedic Department.
Where was it?
At the University of Calgary.
So in Canada.
In Canada, yeah.
So welcome to the United States.
Yeah, I'm a refugee from north of the border. So the university was very dedicated to problem solving in the orthopedic department and using the civil engineers as ways to take our ideas of problems and how we would then transform them into solutions.
Yeah.
And so we had quite a bit of experience with that over the time that I was at that university.
So what is the value of engineering and technology in medicine?
It simplifies, it purifies the problem, so that you can take something that many things are done by habit over the years, but not necessarily the most efficient way. And then if you have somebody with a new insight, and engineers are particularly gifted at this, of taking a problem and then correcting that problem and finding a solution for you. And then the surgeons have to be part of that part of one of those moving parts. Because we're the ones who actually have to implement it, and we're literally where the rubber meets the road. So, so the engineers are co-buddies in the development of the technology, and then we're the ones who actually have to implement it.
And I would go even a step forward. I would say that the value of the technology in medicine is to making impossible possible. Let me give you an example. Can you imagine how the surgeries used to be when we didn't have electrocautery? Like something we use electricity in the OR, either with one pen that drives the electricity to body and heats up and stop the bleeding, or bipolar, where two poles of electricity come together and a very distinct area stop the bleeding. Can you imagine doing any of our surgeries without electrocautery?
I actually trained with surgeons who didn't believe in using electrocautery.
How did they stop the bleeding?
There was a lot of pressure, time, and then ligation.
Ligation, yes. Can you tell us about that? Because I still remember that, and I can tell you, no spine surgery would be possible with that method.
Well,
But
one of the instruments that's pervasive in every operating room to this day is an instrument called a hemostat. And if you take that word apart, it's the hemo for blood and the stat for
it's a
stasis.
forceps. It's a forceps.
It's a forceps.
It's not a it's not a electrical device or anything. It is a forceps with a very thin tips
Right.
that you literally go ahead.
And the idea was that you would pinch off the area that was bleeding. And
The
then
artery, small artery.
small arteries or larger blood vessels. And then you would then pass a stitch around that to sew it down and stop the bleeding. And so you would be doing surgeries where you could spend the better part of an hour and a half in an operation just sewing up the bleeding areas.
So let me give you an example. When Harvey Cushing was doing, or in that time frame, before they had this electrocautery, a surgery, a brain surgery, was a whole day, 24 hours sometimes endeavor. And because when you caught in the skull, all the small little vessels start bleeding, and then either they would use a hemostat, or later on we had something clamp that goes on the skin outside and inside and clamps it together. We still use that, by the way. But considering that just stopping the bleeding so patient doesn't bleed out in the OR was a big deal. Now we don't even think twice. We get the BOVI, which is that electrocautery. We just coagulate the vessels, and then we can go actually do the actual surgery.
Yeah, so it's allowed. I've seen in the evolution of my surgery with the techniques we do, many of the procedures that we historically had been giving blood transfusions for postoperatively, we no longer have to do that.
Yeah.
So that changes the safety profile dramatically when you're not using adjunct things like blood transfusions. A little unknown thing that I hope gets some traction and some research. Shoulder surgery, which is what I focus on a lot in my work. When we cut through the skin, there's a high propensity of development of infections from the same bacteria that causes acne. And so there's been a lot of research on how do we avoid that, and different topical things that we can put on the skin to try to sterilize the skin before we cut it. But none of them have proven to be ultimately truly effective, so that you would think that it would make it very difficult for us to do shoulder surgery. But I have a suspicion that one of the things that's made it easy to do is this exactly the electrocautery. When we cut through the skin with a scalpel, but then we immediately move to the electrocoagulation. And I believe
bipolar?
And I believe that what we're doing is we're cooking the bad bacteria immediately below the skin, so we're not getting infections with them.
Okay.
So
do you see that practically the technology opened doors for us, like many surgeries that used to be extremely risky, and this is just one example, the electrocautery. But you and you are orthopedic surgeon. I'm a neurosurgeon specialized in the minimal invasive spine surgery. Let me tell you, the first time I watched a spinal fusion and participated, and that is not that long ago. I mean, yes, it is maybe soon to be 20 years, but that surgery is still being done. It was a one-level fusion, a TLIF, transforaminal lumbar into body fusion. It was 7 hours. Skin to skin, it was 7 hours, and then add another hour for anesthesia. It was an 8 hour, one room, everybody there for a whole day, one surgery for one level. That patient stayed in the hospital 2.5 weeks. And then after that went to rehab. We had about half a gallon of blood loss. And it was painful to see how slow the recovery of that patient. Just today morning, I did the same surgery in a surgery center on a patient, same level actually, L4-5. The surgery was 27 minutes. Our blood loss was 2 ounces, and that patient is already home. And that is 20 years of development. Now, obviously, we do a very specialized technique and so on. We will talk about that. But this is not surgeon skill alone. This is a whole new technology. And it's not only a device or one device. It is practically an accumulation of what can we do different and what does it take to make a long surgery and risky surgery a shorter and less risky surgery. Thousands and thousands of people are involved in that. Give me a few examples from your from your field. How was it done before? How is it done now? What amazes you?
Well, let me back up just a little bit. I mean, when you say in my field, I started out as a family doctor, and part of that training, we had to do what was called an internship. And I remember I was the guy who had to go up on the surgical floor on Monday afternoon and admit all the patients who were coming in for Tuesday cataracts. So they came in on Monday afternoon, had surgery on Tuesday, and then I had to come see them every day until they were discharged on Friday. So that was a 5-day event for that patient to have a cataract surgery. Now a cataract surgery is not done under local anesthetic, and the patients are going home about 30 minutes after they've had their procedure. So that's one of the more startling ones that I've seen develop in my life. When I first got into orthopedic surgery, we were just at the cusp of beginning to use camera systems into joints to look at things. We still had some of the older surgeons who would somebody had a torn meniscus in their knee. They'd still open up the knee and they'd rip out the entire meniscus, and you doom that individual to have arthritis for their knee, guaranteed at some point later in their life. Then along came arthroscopy and the idea of minimally invasive surgery to get into joints. I remember having an argument with one of our senior orthopedic surgeons about a patient with an infected shoulder. And I was a freshman resident, and I said, well, why don't we just go through the back of the shoulder to get into the shoulder, because there's less musculature. It'd be simpler to go in that way.
What did they say?
They reassured me that I was an idiot and that there was no way that technology, you should be going that way. You should open up the whole front of the shoulder to gain access. And here we are now 35 years after that discussion. And we have patients who come in with an infection. And what do? We go through the back of the shoulder and we put a small camera in there and make about a 1/4 of an inch incision, and we can treat them very efficiently through that way and very safely.
Do you know what the concept you just described? It's called thinking outside of the box.
And unfortunately, in medicine, that doesn't usually go well for the newcomers.
Well,
the box is very strong and very defined, and people
defiant.
And people don't like you thinking outside of that squared cube.
It is something that it's not really evidence-based medicine, it's eminent-based medicine, meaning that few important or self-called important people do certain things certain way, everybody else follows, and everybody who's outside of that line is practically dismissed. Now, it is what we discussed today. Actually, you and I, we were in lunch, we discussed that we have somebody in our group that she doesn't know how things are done. She just goes and does it the way she thinks is the right way. Imagine you could 30 years ago do what you just said. You would be the person who ushers a new area if you could have done it.
The technology hadn't quite arrived at that point, but but eventually it evolved and the technology became possible, and now it just seems so common sense that you would do it the way you're suggesting.
So you weren't that out of line.
But
it just was you were avant-garde.
The senior professors didn't take it too kindly to a junior resident disagreeing with them on that.
Yes, and and that is exactly the point that we say about the medicine. Medicine is a very conservative field for a good reason, mostly. But once in a while, you have this kind of episodes that something that is out of the common understanding of eminent-based medicine get dismissed, and lots of patients have to pay the price.
And that certainly has happened. Like, as you said, the evolution in medicine by necessity has to be very measured. We have to be very careful about moving on to fringe things too quickly. Mm-hmm. I've been around the game long enough that I've seen a number of new thought become
they didn't cash out,
and they crashed and burned. They didn't work well. So we have to be cautious about being too avant-garde about doing things. Mm-hmm. On the other hand, where medicine is maybe a bit of a dinosaur is that when something truly is transformative, and the whole idea of arthroscopy, of looking into joints to do things, one of the most senior shoulder surgeons in the entire world, almost to the day he died 10 years ago, considered arthroscopy to be the tool of the devil, and he'd use those words. As a consequence, he dissuaded a number of people for a long time about adopting the new technology. And so every
Did
once
he
in a
have
while,
any evidence for that?
no, it was just personal opinion.
Personal opinion.
Yeah.
And that is exactly, I think, where we can all agree on. Medicine is a science. And it's based on collection and interpretation and evaluation of data.
But some of this data takes so long to create.
Yeah.
There'll be some data that I'll be dead before I will ever find out the results of things that I would like to know now. But so the pushback from technology is sometimes appropriate, but the adoption of the truly transformative technology hits resistance as well, because if people go, no, that can't be possible. You can't be doing it that easily now.
Let's
Whereas
talk about
before-
our personal relationship and personal, experience together in Crookston. Okay, so you have been for a long time chief medical officer, or tell me about your role and how did we get to know each other?
Well, we'll go back half a step from there. Was that my prior existence before crossing the border and becoming a resident and citizen in the United States was I was a professor teaching at the University of Calgary, and my role was to have orthopedic residents and then some orthopedic fellows from different parts of the world, and then try to do research and learn what were the most elevated ways we could manage the different pathologies we were dealing with. So the Canadian health system, being what it was, became a quite frustrating place to work within, and I ended up moving across the border and ended up in a small town with just 8,000 people in a 25-bed hospital that didn't even have an orthopedic program. And so I basically took it from scratch and started building it. But what was interesting about setting it up from the ground level upwards was I was able to take to a small town the standards and principles that I was trained to do in a university level setting. So most small hospitals don't start from that basis. So that's the premise by which we started building a surgical service in a very small hospital, was to have very capable subspecialty surgeons doing very high-end technology within the building. So an example of the commitment to that was when the very first 3 Tesla MRI scanners became available. This little town decided we were going to have that because if we were going to do all of this high-end technology surgery, we needed all of the high-end technology resources to be able to do for diagnosing. So we put all that in place, and then about a decade ago, you showed up as a neurosurgeon, spine surgeon, and what I've had the fortune of watching develop is the evolution of the transformation of spine surgery from what I was trained to do, which was big open operations, as you said, these 7-8 hour marathons that were quite debilitating to the patients, but a strong commitment to how do we transform that into something more simplified and safer. And so the micro-invasive technology is what you've been pushing for the last decade. And I've seen that transform so that I've now personally seen these patients who have gone from having 7 or 8 hour operations to now having 30-minute operations and going home the same day or the next day.
But let's talk about that. What is wrong with the 7-8 hours operation? Why is it even a problem?
Well,
I mean, because lots of people who are not in our field won't understand that.
Well, why would you not want to have a 7 or 8 hour operation under general anesthetic? Firstly, you're on a breathing machine for the entirety of that time. Secondly, your body's lying in a stagnant position for a long period of time. So those two things alone can produce complications of their own, such as blood clots or difficulty with breathing after the procedure. Any operation where the wound is open for that length of time is going to have a substantial increased risk of infection. And then there's all of the secondary effects of you dissect all of those large areas, you have less blood supply coming to them, so you're going to have a higher risk for infection, a higher risk of failure of the procedure, the bone growth after a fusion in the back, or any bone for that matter.
Yeah.
The chances of success in the procedure gets less the longer you have the area open. So any technique that shortens that length of time, reduces the blood loss, reduces the dissection, all of them, it leads to a better final outcome, And I
In
think
any field, in any part of the
any part of the
medicine.
body. Like,
Yeah.
anybody who's had their gallbladder taken out in the last 20 years doesn't understand that 30 years ago there used to be about a foot-long cut across the side of your belly to take out your gallbladder, and it would take you about 6 to 8 weeks to get better. Now we take out a gallbladder, people go home the same day or the next day, and then they're back at work 2 days later.
Yeah.
They've forgotten just how much trauma we used to inflict on people.
And the mortality, morbidity that we used to accept for many of those surgery would be unacceptable today.
Exactly. Yeah. So watching you transform spine surgery in this fashion, and spine surgery, unfortunately, has been a bit of a laggard as far as adopting these newer technologies. The general surgeons have been very good about moving into this new kind of technology.
But they moved through their episode of resisting the laparoscopy.
Yeah, they've all had their time in the sun of that pushback, and but most of them have made that transformation 10, 20 years ago. And orthopedics, for the most part, has made that transformation 10, 20 years ago. Spine surgery, in
It's
part
the
because
boat.
is on the bubble of making that transformation. Now, again, part of it is it's not just having the willingness to make the transformation; it was also having the technology to make
An
the
ability.
transformation. And now we finally are. I think we're arriving at the point where the technology and the willingness are mashing together, and now we have to move the expectation to that.
Yeah. About 3 years ago, I talked to a general surgeon who just retired, and it gave me a backstory about the development of laparoscopy in general surgery. Number one, laparoscopy was not developed in the universities. Number two, most of the universities and lots of eminent surgeons fought it to tooth and nail until they retired. Number three, once it was accepted and brought in to the universities, it really spread out. And number four, there is a good evidence that our medical system would break down if we would take like laparoscopic, endoscopic techniques out of general surgery. That is just in the general surgery, and it took them about 10 to 15 years to truly go through that phase. Because as we talked about, people who are used to do something some way, even without evidence, will just stick to that. And their justification not to learn new thing is that the other thing is not working. And now I have two answers to some of my cynical colleagues that they say, no, the MIS or minimal invasive doesn't work and we don't believe in that and so on. And longer surgery is not risky, which is, by the way, completely debunked, that longer surgery doesn't really affect the outcome. Now, my first question, how I answer to regular layperson people is that, what do you think if a surgery is half an hour versus 3 hours or 7 hours? What do you think what the surgeon is doing in that time frame? We are cutting the tissue because bleeding. We cook the tissue to stop the bleeding, and then we move on and forward and forward. Now imagine doing it half an hour or 7 hours. The amount of the tissue damage you produce is not the same. And secondly, for my colleagues who say that, this is the fact that based on studies that we will put the reference in the comment section, that every additional half an hour under anesthesia adds 17% to the combined risk of the surgery. This is across the board. And in prone, when patient is laying on the chest, that rate is even higher. But generally, every additional half an hour on the surgery adds 17% to the combined risk of the surgery. The math works in a way that all the surgeries that are less than 2 hours have half of the complication rate of the surgeries that are more than 2 hours. This linear kind of progression of the risk is well proven and even get worse. If you are an elderly, meaning you're 75 years of age and older, after 3 hours, that steepness of this curve goes even much higher. That is why for elderly, surgery is more than 3 hours, especially in elderly as well in young people. Just being on the anesthesia for that long, anesthesia gas, causes significant cerebral kind of the deficits that in the detailed neuropsychological test, they have found out just being under gas, anesthesia, and so on for prolonged period of time. This doesn't go unnoticed on our nervous system. So
it's incumbent on us whenever we can
Safety.
to move to a technology that can achieve the end final result equally or better, and then do it with a safety profile that's equal or better. And so when we see those opportunities, that's when we need to basically retrain ourselves. How do we move forward in the technology? So I do find it kind of frustrating when I see surgeons of my age or even a decade younger than me that are reluctant to take on new technology when it's demonstrably better than what was available before.
Tell me about one of your shoulder surgeries that you do, and I know you're an expert on. Just first of all, how long does it take you to do that? What is your outcome? What have you seen out there? How long it takes? What is that outcome? And what do you do different to make it happen?
Well, let's use a shoulder replacement.
Arthroplasty, shoulder arthroplasty.
Shoulder arthroplasty, where we're putting a new ball and socket into the shoulder. When I first trained on doing that procedure, it was roughly about a 3.5 hour operation. And as a consequence, with the wound open, there was more bleeding. Not uncommon for us to have to do a post-surgical transfusion for the patient, giving them some blood. The technology has improved as time has gone on. The instrumentation has been made better to make access easier. And the surgeon who does it to this day still makes about a foot-long incision across the shoulder to gain access. So there's ones that like myself who do the procedure perhaps more quickly, because we can now accomplish a shoulder replacement in a typical patient between 50 and 55 minutes. And our blood loss is now down to roughly about 6 or 7 teaspoons of blood. And how do we accomplish that? Well, it's the better technology, but secondly, it's an increased familiarity. With all these operations, there's a learning curve. You don't start off being able to do it this way, but there has to be a willingness to say, okay, this is the ultimate goal that you're trying to get to, and this is what you need to be taught how to do. I had the interesting experience of going down to Texas to one of the universities there to watch them, how they were training their top level people. They weren't the practicing orthopedic surgeons, or what they're called fellows. So they're already graduated orthopedic surgeons, but they're being trained into a specialty. And unfortunately, when I was watching it, they took longer to do the procedure to get down to the shoulder than it takes me to do the entire operation.
What were they doing differently than you?
They were fussing about details that don't make any difference in the ultimate answer to the
understanding what matters and what not matters.
Exactly. And so you have to have a clear understanding of the things that how you can manipulate the tissues in a way that is safe, and understand which things matter in the sequence of the operation. And in part, it's having a team that understands the entire steps, so they can go very quickly through the procedure. In my operating room, when we're doing a total shoulder replacement, there's almost no verbal communication. Everybody in that room knows exactly what the next step's going to be and when we're going to do it. So
and that leads us to smaller places with a well-tuned group can do, for most of routine surgeries, they can do much better job. You're in a small place, you do that in 55 minutes. They are in a university where surgeon and the nurse not necessarily are always the same people.
Right. I've got a group of four surgical scrub techs that work with me. They all know the technology. They all know exactly what I'm going to be doing.
You don't need to talk.
Right.
You just, the next instrument is already there for you.
Yeah, exactly. And I've got one surgical assistant who works with me, who's been with me now for 20 years. And so again, we don't have to speak much when we're doing these procedures. And that was
one of the things. Today I had a visitor, a neurosurgeon from Oman, who's right now in Massachusetts, that observed my surgery. That is one of the things he said today at lunch, that I didn't have to talk to my scrub tech at all.
But if you go to a major university setting, you may have one of 50 different scrub nurses work with you. You may not have an assistant at all. The residents may be coming and going. So the team is very variable in that kind of environment. So the
result will be accordingly variable.
Exactly. So the dogma is the bigger must be better. But in many things in surgery, that's not the case. You get to a small defined group that's very consistent what they do. The outcomes can be phenomenal in that kind of environment. And it doesn't have to be in a big city. And we're proving it, doing it in a town of 8,000.
So tell me about that this musculoskeletal service that we have in our place in Crookston. Tell me about what are the procedures that we are doing, and what is comparable out there. Like, you do your shoulder surgeries. I know we do other arthroplasties there. I do spine with Dr. Kim, and I can tell you from my part. People drive from Rochester, from Mayo, from the cities, and you have seen them to Crookston to get their medical care. People cancel their surgeries from Oregon, Chicago, Arizona, Phoenix, from major places. They come to us, to Crookston, from all places, to get their medical care because something has changed. The internet gives the people the opportunity to inform themselves. So, in your field, what are those procedures that you are truly proud of being able to provide at that level in Crookston?
Well, there's a number of things that I do as far as reconstructive work. A good 50%, if not 60% of my practice is reconstructive work of the shoulder. So it's either arthritis or the reconstructive work for damaged tendons and rotator cuff disease. So that makes up a huge portion of what I'm doing in the operating room on a day-to-day basis. And I'm also what I consider to be an upper extremity surgeon, so I'm doing elbow and hand procedures as well. Mm-hmm. And some of the wrist operations I'm doing are very much at the forefront of procedures that are being done in the world. We're doing wrist replacements for major arthritis. We do a number of arthroscopic procedures, both at the elbow and the wrist and the shoulder. So there's a variety of things where we've, in Crookston, have actually been the first place in some cases in the world to do certain procedures. And it's been interesting having that opportunity to take some of this newest technology and apply it before anybody else in the world has done.
Give me some examples.
Well, one of the examples is when somebody has had a shoulder replacement done, the rotator cuff, the muscles that move the shoulder, has failed. We didn't have a good way of converting that replacement to the newer technology of something called a reverse total shoulder. One of the companies that I work with, Biomed Engineering, had come up with a way of taking part of the implants and then taking some of the old parts out and then putting new ones in, but leaving parts still in place. But that had never been tried before. And when they finally came up with what they thought was a satisfactory answer for it, I was the first location in the world where we attempted to make that kind of conversion. In fact, they had their engineer from Warsaw, Indiana, in the operating room in Crookston. And I remember distinctly once he saw that the reimplantation had worked really well, he was on the phone calling the Hospital for Special Services in New York City, which is supposed to be the mega center for orthopedics, and giving them permission to go ahead and do the second procedure. So, and then there's a newer device that the Israelis have developed. For all intents and purposes, it looks like a tiny little breast implant that's now being used in shoulders. It's put in arthroscopically.
I'm totally confused.
Yeah.
A breast implant go from the shoulder?
It's a little bag of saline that
Is it go under the axilla?
No, goes right in under the shoulder blade, and it's used to supplement for when patients have a bad torn rotator cuff. Well, that was approved by the FDA in July of 2021, and I was the first person in the entire Upper Midwest to utilize that technology. So we've had a number of different opportunities to take some of this newest technology and use it before the universities are using it, before the major hospitals are using it.
Now, the development of the technology in medicine is obviously, we talked about that, it's conservative, the uphill battle, you have to look at the evidence, you have to gather the evidence. If you have a great idea in your field, what do you think, what advice do you give to people? What the best way of doing it, to give you the best successful path?
I don't know that I'm the best person now, because I thought I've had some great ideas that have never been able to really push forward to that final conclusion. I would say that the hardest thing is it has to be safe. You can never do anything that's not safe, because the world of surgery is replete with people who've tried half-baked things have not turned out well, and then people have had to have their products recalled, and it's a huge disaster when that happens.
So I will say have a critical, self-checking mind that always the first priority. Well, am I doing something safe or not?
Right, and so it becomes, this is where you have to be in hand in step with the engineers. You have to be able to take a look at the technology and say, can we create this in some fashion that's going to be reproducible and useful?
One of our viewers is asking, what are your thoughts on the future of cartilage repair? What do you think, expert?
Well, the university where I trained, the University of Calgary, that was actually the foremost area of research at the Musculoskeletal Research Center, and that was in 1986 to this very day. And so we're looking at what I've had an opportunity to observe this over the last 35 years. We're getting closer. We still are a long way from final solutions in cartilage repair. When we talk about cartilage, we're talking about that very elegant material that lives on the end of the bones that makes up our joints, that is essentially a frictionless medium in which the two bones can move past each other without producing any friction and disruption. So trying to replace that when it is damaged has been the holy grail of anybody dealing with musculoskeletal problems.
Most of the time, we just replace it with the synthetic material.
Well, that's what we've got for the moment. We've had one of two options: either we fuse something together so that area of cartilage no longer moves, or we replace it with something. So we have hip replacements, knee replacements, shoulder replacement, wrist replacement, elbow replacements, all of these things. But ultimately, that mechanical device is going into that person with no maintenance for the rest of their life. And it either survives long enough that they die with it in, or it fails at some point.
And then you have to be replaced.
Then have to replace. And the revision replacements are never quite as successful as the originals.
Why? Why is that?
Because of all of what you've done just to get in there the first time. You've cut things, you've traumatized the tissue, they've scarred down.
Because every surgery is a trauma.
Every surgery is a trauma.
Longer surgery is more trauma.
And the less you can do to get the implants in, the better. So you do
Here
less
you
trauma.
are.
But ultimately, there's still a mechanical device. So the holy grail of orthopedics is, can we come up with some way so we can rebuild cartilage without going through those steps?
Can we?
We're trying.
So not yet, not today.
Well, we're getting closer. But the idea of having some sort of magical spackle that we can put onto that surface and smooth it off again, we're not there yet. But there are many people out there who are trying to sell that we're there yet. And we're not. We haven't
Explain.
Well, one of the examples most recently has been a lot of people being told that they're going to have a stem cell injection into their joints.
And that's going to give them a whole new joint.
And the stem cells are going to repopulate, and they're going to rebuild the cartilage, and everything will be wonderful. Well, the FDA, if you use those words out of your mouth now as a practicing physician, you're probably going to get fined, if not put in jail.
Yeah. So that would be not true.
Exactly.
Any kind of idea that you put some stem cells in a joint or anywhere in our musculoskeletal system, and it will rejuvenate your joint, that is not true.
We're not there yet.
Okay.
There are many people working on animals. There's a lot of sheep dying, a lot of rabbits dying in laboratories, trying to figure out how can we rebuild cartilage. But there's an optimism that we'll get there. Sometimes this optimism has been preceded by people willing to sell you the product before they're ready to go. But I don't know that it's going to happen in my lifetime. As I've seen 35 years ago, I thought we were just around the corner from it. And we're still not there yet.
But so let's recapture that. The stem cell therapy or any kind of like a plasma therapy or any other kind of therapy that they inject something in your joint and that rejuvenate your joint, it may be promising in the future, but in 2022, that is not the fact that can be done. Now, let's talk about the arthroplasties, because that is widely successful by itself. What is the average? I can tell as well about arthroplasty in spine. Now, spine is one of the most complex joint system. It's not like one joint. There are 3 joints in the spine. the disc itself and two facets in the back, two joint, their connection is extremely complex. It is not like one joint that moves in one way. As a matter of fact, the center of rotation changes depending on what position spine is. And in spine, for last 10-20 years, we have come up with spine arthroplasties. In the neck, it seems that compared to fusion, they give no additional benefit to fusion. Just a paper came out that even in the long run, we were hoping that if you do arthroplasty versus fusion, that the chance that the next segment get bad is reduced. That is not the case. So in the neck, arthroplasty and fusion have similar results. With the fusion, we have 30-50 years results. For arthroplasty, we don't know how long those joints are going to last. We just don't know. In the lumbar spine, it's even worse. That there are good evidence that fusion is much better than arthroplasty, or in our case we call that disc arthroplasty. Especially for the disc arthroplasty in the lumbar spine, we have to open up the belly, go through major vessels, and that is much bigger surgery, and the revisions are extremely more dangerous. Let's talk about your field and arthroplasty like shoulder, where you are truly an expert. How long do you expect them to last? What is the natural evolution? What did you use 20 years ago, 10 years ago, and today?
We're almost every major joint where we're doing this joint replacement or arthroplasty, it involves some sort of metal surface articulating with some sort of plastic surface. And
but they used in the past metal on metal, right?
That has been done, and
why do you abandon that?
Unfortunately, in almost the issue is that there's always some wear between these two surfaces, and with metal against metal, there's been the breakdown of the metal itself, and then the absorption of the metal into the human body. And there wasn't much concern about that was a major issue until an orthopedic surgeon up in Alaska had a metal-on-metal hip replacement and then became cognitively impaired to the point where he couldn't practice anymore. They found out that the cobalt levels in his body had gone extremely high. And so until he had the implant taken out and the cobalt levels came back to normal, and it took him almost 5 years before he was able to get back into practice. But he was the one who was sort of a individual case study that proved the point that this metal-on-metal debris that develops.
It doesn't mean he was the only person, but he was intellectually savvy enough to make the connection.
Exactly. And then he proved it to the world that this was a legitimate issue. So the willingness of the industry now to create metal-on-metal implants has diminished substantially. So we're back using principally a metal against a plastic surface. Now, when I first started as a resident back in the mid-1980s, a good chunk of our day was spent revising hip replacements that had been done with metal on plastic implants done in the 70s. And
so we started with metal on plastic, went to metal on metal, and now we are back to...
And the metal on plastic ones from the 70s, we would take them out, and then there would be all of this debris within the joint, and it was causing further damage from the inflammation of the body trying to absorb these foreign bodies. So the engineers, again, they sat down and looked at this issue and tried to come up with different ways to modify what was doing. So you couldn't do a whole lot on the metal side, but they certainly did get much better on the plastic side. So that the new plastics that we have that make up the other half of the joints are wearing much better.
What is it? What kind of plastic is it?
It's a polyethylene material.
Polyethylene. Same thing that the wheels of your skateboards are made of, by the way.
Yeah, exactly. But maybe a little bit more sophisticated engineering than that. But if anybody remembers the old IKEA commercials looking at mattresses, and they'd have this little machine that would thump down on the mattress 10 million times to prove that the mattress wasn't going to break down. Well, they have similar kind of things in the labs looking at the wear pattern on these joint surfaces.
How many cycles do they change?
They're getting well over 100 million cycles on these without any evidence of wear on the product.
100 million? Yeah. That's a lot.
It's a lot. So what it translates to in the real world is if we implant one, what does it mean as far as how long should it last within your body without causing a problem? And I'm telling my patients that our current technology should last for about 25 years and potentially as much as 30.
That is for joints that is one motion, and the motion center of pivoting of the motion is...
Well, the hip is about the closest to get to that simplified version. The shoulder is much more complex than that. Elbows are far more complex
but
than that.
But even there, the elbow or the shoulder, there is one surface it's not like there are three joints that together. What I'm getting at, those technologies, they don't work in the spine
Yeah.
because every time they try to replace that put too much pressure on the facet. It actually separates the facet to a point that within a year or two, the facet wears off.
Well, here I think there is some commonality with the other parts of the musculoskeletal system. Is in the bigger joints, I think, and that's probably where it matters. Is size matters. So if you're looking at a hip, a shoulder, a knee, there's a very large mass of bone that we have to fixate the device to. And the biggest problem with long-term implants is they loosen over time. With the big joints, you have a large bone surface area for the bone and the implant to connect. And so that allows you to distribute forces, and that allows to reduce the amount of friction between the surfaces, and it gives a better longevity. On our smaller joints, and I'll give an example of this, the fingers and the thumb. They
have artificial joint for the finger and thumbs?
Certainly we do. And they can become arthritic just like any other place. And but
there's so many of them. Do you replace all of them?
And we have in the past with very simplified things like silicone implants that kind of bend. So basically we call them rubber knuckles. But anytime somebody's tried to replicate a style of implant that's a metal with a polyethylene surface to articulate against, those small bones, there's not as much space to gain traction with them. You don't have much implanting substance to work with. And they all look really nice on their x-rays the first day after surgery. And almost inevitably, they all fail within about 18 months to 2 years, because there's so much force on these little joints. When, how many times a day do you pinch with your thumb?
Yeah.
And you put an implant in the bottom of the thumb? It may look good for a little while, but eventually they loosen. And then you got a real problem that you've put something in that now you got to take it out. And now what do you do with that joint? So I would suspect that a big measure of problem with the facet joints in the spine is the same issue. Is anytime you're trying to put a surface in there, you've got a very small surface contact area, and trying to get something that can integrate with that small surface with the degree of forces that are applied to it and expect longevity out of it is almost impossible.
As well, that is one point. And the other point is that I listened to a biomechanical engineer that was explaining the biomechanics of these devices. Imagine on your door in your house, you have three joints. And you replace one of them. We usually don't replace facets. We just put a disc there. And if they are not truly aligned, that all three joints will have wear and tear and destroy them. If imagine you take one of the hinges out and put another hinge that it's only quarter of an inch further in or out. So they are not truly aligned. Nature over millions of years has made those joints truly aligned and moving in harmony. Now you go and take one thing out and put something in that truly not aligned with the other three joints, it destroys all three of them. That is how he was explaining it. But he has as well the data to support that. He would show what the forces are on these facets.
And that makes perfect sense. But the degree of stress across those areas is substantial. And again, how many times a day do you bend your back and move your back? So the repetition is phenomenal.
Yeah.
And yet the body mass area, like let's say we're just putting a replacement disc in, that's so much smaller than a replacement knee or a replacement shoulder or a replacement hip. And that by shrinking it down, it gives us that much less contact area to stabilize things. And that's going to be the magic of engineering. One day, will they succeed one day? Yeah, they will. I'll be stardust when that happens. But the engineers will figure it out one day. But we're not there yet.
Not yet.
And that's the limiting step right now for that kind of technology.
But lots of things we do today is already science fiction, even 20 years ago.
Oh, true.
If you'd have told me that I can do a one-level fusion in half an hour and send the patient home same day, even today, most of people don't believe that. That, like, this surgeon who came from Massachusetts was watching my result on LinkedIn, and he was saying, this is not possible. But I think he had the same blessing that I had 10 years ago. When somebody told me that somebody does this one-level fusion in under 1 hour and patient go home same day, I said, it's impossible, but I want to see it. And he, as well, today, really didn't believe. So for many things we do today is already science fiction for even a quarter of a generation ago.
We're in the small town where we're working. We're blessed with an extraordinarily talented hip and knee surgeon. And the very first day he showed up, he was late to get to the operating room, and he had a total joint replacement scheduled for, I think it was about 12:30 in the afternoon. And he got there about quarter to one. And then I was talking to him in the doctor's lounge at 1:05, and I asked him, well, what was wrong? And he said, nothing's wrong. And I said, well, what about your case? And he says, I'm done. And he had managed to finish that case in 20 minutes. And when I go back to when I trained, anything under an hour and a half for a total joint replacement was considered phenomenal. So it's some of it's from the expertise of the surgeons. We're getting better. If you'd have told the 20-year-ago me that I could do a total shoulder in 50 minutes, I wouldn't have believed you. So it's the adaptation of the newer technologies and newer techniques, and plus the evolution of a lot of experience. Like when I was trained, we had one surgeon who did shoulder replacements, and so that was the basis by which you judged everything. And now we've got thousands of people who know how to do shoulder replacements.
Yeah.
So we're getting better at it because the orthopedic community is deeper now as far as what we can do.
The trivia in medicine, they did a study to see the expertise level of lots of different doctors. This is based on that. I'm not sure if I completely agree with that, but they've estimated that the best expertise a doctor has is between the 5th and 10th years after residency. Before that, they're lacking experience. After that, they're lacking new method and knowledge, except for surgeons. Surgeons keep improving even way beyond that, because for us, it's a technical, it's a handyman work, it's a something that our muscle memory keep improving and improving and improving.
I agree with that, but as a teacher of surgery, where I think that the biggest change with time is in the decision on who gets an operation.
It's very true.
That ultimately, at the end of the day, we're technicians who do a job, but the favorability and outcomes is determined by can you pick up the problem, and sometimes it's not so obvious, and that you arrive at the right conclusion of what's wrong. And then from the armamentarium of things that you've seen applied to that problem, can you pick the right one that's going to fix that solution for that patient?
Yeah. Harder sometimes.
And that experience is
gold. Yeah.
That's gold, and that's not something you have at 5 years. It's not something you have at 10 years. As the decades go by, if you're attentive to what you do, then that's where you move into an elite level of surgery, because you're picking the right people to do the right operations to.
And I have heard from many experienced surgeons that it is harder, the older you get, it's harder to make it right decision rather than to do the surgery. Once you decided what you want to do, the surgery itself become a trivial thing, because you can do that technically, but it is the right thing or not. But there's even another level to what you just said, is that many times we are surgeons, we want to be active. Many times it is hard. We are just, our fingers are itching. Should I do that surgery or not? Being able to hold back and say, let's be patient. Let's just not jump to conclusion. Let's not jump to surgery. That I find to be even a harder decision, just to be patient and not jump prematurely to the surgery.
Well, this is where I'm going to pull out the old man, I'm wiser than you stage. Another decade of practice, that's become easier now.
Yeah.
You do recognize your limitations. You do recognize the other adjunct things around that. Is this the right thing for that one patient? You can't apply everything to everybody the same way. So I've actually found it easier to explain to patients that this isn't something that's likely to have a good outcome because of all of these factors, and they're adjusted specifically for that individual. Mm-hmm. That's become easier for me to explain as years go by. It used to be I would think that they've come to me and I'm responsible to provide the solution, and sometimes that solution is not possible.
Risk versus benefit.
Exactly, but now that I've had 32 years of experience as a shoulder surgeon and a hand surgeon, I'm learning more about what can I truly accomplish and what can't I accomplish, and not to oversell those expectations.
Yeah.
And it's actually, now that I've come to peace with that within myself, it's easier to explain it to patients. And as long as you're open with them, they're more practical. They understand that we're not always possible to solve their problem.
In the last 10 minutes of this conversation, actually, that I like to talk about your observation about Olaf. You have seen me often very frustrated that I try to teach the Olaf technique, oblique lateral posterior lumbar into body fusion, the technique that we have truly make it perfect in Crookston and here, and people are coming from around the world, not only for us to help them with that, but as well surgeon to come and learn that. You have many times seen my frustration about the hesitancy of my colleagues to accept that. Now, many times they recite that the experience is not enough, the complication is high, and so on and so forth. And if you remember, you and I, we made a TikTok together about that, as somebody whose job is to look over the result of those surgery in the hospital, since you were the chief medical officer of the whole hospital, and that's your job to see how those patients are doing. Now, in the last 10 years, I talked to our internal medicine doctor, was telling me that since we are doing that 80% less complication, medical complication, but as a chief medical officer, as a surgeon, as a doctor and physician, and as somebody who's on the hospital side, to make sure that we are providing the safe service to our patient. Why don't you tell me about your personal observation about when we transition from open surgery to MIS spine surgery, the Olaf procedure?
Well, if we look back, what goes wrong with the procedures the way they were done before? And there was the most common things. One was relatively minor, but still very aggravating for the patients. And that when you cut through the tissue in the back, many people are overweight. They've got about 3 or 4 inches of fat in the lower part of the back. And you cut through that tissue and they would end up with some drainage. And then occasionally that would end up getting infected. So it would be relatively superficial infections, but sometimes it would become a deeper infection. And so then you'd have to pack these wounds open, and then you'd have to get them on IV antibiotics. And so
post-operative wound infection.
Post-operative wound infection. And not common. In a good hospital, you're running those
It is
kind of
3
issues.
to 5% in the spine.
Right. And in our particular facility, I think we were lower than that. We were down about 1 to 2%, but it's still enough if you do enough volume of patients that there's always going to be a few that are out there, and it's a problem for them. So that was the number one issue. Number two issue is that the standard.
But what was our rate of infection with Olaf after we transitioned to Olaf?
Well, when we transitioned to Olaf, our infection rate has become almost negligible. I think we've had 5 in the last 10 years.
Well, I can tell you about my data that after 1,500 cases in all hospitals, including Crookston, my rate of infection has been 3 in 1,500 patients, so 0.17%, and not a single take back to surgery for lumbar spine. I'm not talking about the other areas that are different surgeries.
Right. So it's a transformative operation in that respect alone.
1/30 is the risk of infection.
Right. That's phenomenal when you start talking things like that. Now, does it make it impossible to get an infection? No, anything's possible. But this has changed it from being where it was always some of them out there to being where now it becomes extraordinarily unusual to see something happen. So that's the number one thing that I've seen change. Secondly, is if we look at, and then this goes back to my training as an orthopedic surgeon, what was the success rate for this kind of operation of making patients feel better about their backs? And everybody is afraid of back surgery, in part because of how things were treated for the last 3 decades, that there was always a reasonable percentage of people who were having their operations not work well, and they would have continued pain, and then they'd go back and they'd have a second operation, then have a third operation. And that kind of repeated surgery was endemic in spine surgery. And there was even a nickname developed for it called failed back syndrome, with all these people with bad backs that just weren't getting better. So if we now have a technology that eliminates the most common cause of that, which is a failed fusion when you're attempting to do the fusion, and you now have also reduced the amount of surgical trauma to the area, the chances of the patients having a quote failed back problem and a failed back syndrome has been reduced substantially. So I'll let you speak more to the results on that, but that's what I've seen over the long term is that we're not seeing these patients coming back for repeated operations. They're getting their surgery done and they're better. And then the third thing that's happened is that two groups have now been exposed or allowed to be exposed to surgery that we didn't want to do before. One are extraordinarily fat people who have where the body mass index was high and over 50. Most spine surgeons don't want to take that risk. It's just too high risk of infection. This technology allows that risk to be bypassed because you use longer tubes to get down where you're going, but the technology is essentially the same. And the other one is older patients. Well, if you before had told you had Granny needed to have spine surgery and Granny was 83 years old, you didn't want to do it to her because that 6-hour operation was probably going to be too hard on her. But now we can reduce the operation to 45 minutes. Granny can have that operation to relieve her discomfort that she couldn't have before. So those are the transitions I've seen over the years.
In the community.
In the community. And it's been legitimate, it's been safe, it's been effective in reducing the morbidity, which is when something goes wrong with surgery. We're not having those kind of problems take place with this. Is it perfect? No. There's no such thing as perfect surgery. There's always going to be a few people who have some issues. But this has certainly reduced the issues, the major issues of spine surgery dramatically. So it's allowing us to utilize it for a much broader group of patients.
Now, just adding to that with numbers, yes, our risk of infection is 1/30th of the open surgery. Our time on the anesthesia is a fraction, and hence the utilization of the OR, even with COVID, was significantly better for our patient. And as well, hospital stay, I think, is a very important fact. Now, hospitals are not the best place to be, especially a lot of sick people are there. And I can just tell you, all of my patients, I did the surgery in Crookston, went home, 8 of them, 5 of them went home, actually 6 of them went home, same day or next day, and 2 of them went home 2 days later. Yeah. And this would have been unimaginable.
And in today's labor market, where we're having such a hard time getting staff to work inside of hospitals, the fact that we don't have 8 patients there 5 days later, and we don't need as many bodies to look after these people. So from a community perspective, we're able to provide the service within the restraints of the available resources.
Yeah. And as a matter of fact, when I did the surgery just 3 days ago, we have another patient that had to be admitted from the ER. We just didn't have the manpower. And we looked at our patient, one of my patients that did a multi-level fusion same day. They said, he's doing great. Are you okay with letting him go home? And I talked to the patient. Patient said, I want to go home. I'm doing great. So we literally opened up a bed for somebody from the ER who otherwise might have shipped somewhere else and so on. This is important for our health system, that we produce less damage, we let the patient recover. And this recovery, faster recovery, as well as with return to work, being off narcotic, it goes on and on and on, that they just get back to their life so much faster. Now, one thing that we always miss, some people, cynic people, may say, those fat people, it is their responsibility to lose weight. They drove themselves. Some of our colleagues unfortunately do that. And as well, regarding the elderly, they say, the grandma has only few more years to live. Why spend resources on such expensive? And this is as cynic as anybody can be. Let's say, forget about the human tragedy of being old and in pain. Let's talk about all the family has to stop what they are doing to help their granny buy grocery, to just get by, to just go from A to B. And we are able to make them independent. You with your shoulder surgeries or other musculoskeletal, and I with my spine surgery. We have evidence after evidence after evidence that we can make these people independent and actually offload the cost of the healthcare. Like I remember a nun who was 93 years old, and for 5 years needed 3 people to just help her to get by. 1 year after the surgery, I have a testimonial of that patient. I have thousands of testimonials that the only thing she needed help with was turning the mattress from one side to another. I need help with that. Okay, being able to make these people independent is not only helping the individual person, which we have to do because that is who we are, but as well that making them independent frees up resources that our society, our healthcare system tremendously needs other places.
Well, it's interesting that the prevalence of this type of pathology within the community.
I apologize. I am on call for all my patients, so if I get a text, I have to just make sure that it is not somebody needing me for my medical sites, okay?
Several years ago, there was an interesting study done where patients of all nature within healthcare were given a Faustian deal. The deal was, how much of the end of your life would you give up to get rid of the pathology you have today? And so they asked patients with heart disease and diabetes and cancer and a variety of different conditions. And then, and along with that were patients with bad arthritis, whether it be at the back or the hip or other areas. And interestingly, the people who were willing to give up the most of the end of their life to get rid of their current problem were patients with bad musculoskeletal disease. And I attribute to the fact that if you have a sore hip, a sore shoulder, a sore back, it doesn't matter what position you get into, it still hurts. If you have a bad heart, you can sit down and not move much, and then at least the pain goes away. So people with bad musculoskeletal disease are the most painful people that have pathology in their bodies. And then the other thing is, if you look at all of the different medical conditions, whether it be diabetes or different medical disorders, you add all of them up together, not one of them has a prevalence in the population of more than 10%, with the exception of musculoskeletal disease. Mm-hmm. Musculoskeletal disease hits 65% of all of the adults. So almost all of us have something wrong with some part of our body, and it affects us on a day-to-day basis.
In spine, it's even worse. By the time you are 50 years old, there is only 34% chance you don't have spine problem. By the time you're 60 years old, it's about 5% chance you never had spine problem. By the time you're 70 years old, there's only 1 to 2% chance you never had spine problem. So meaning that this is something we have to live with. And the idea is here, not only that how much of your life you are willing to give up. There's good studies. If you quit walking, your cardiopulmonary system, the condition shuts down, especially elderly, 75-year-old and older. If they quit walking, you're not trading end of the life. You're calling for the end of life, because your heart lung will shut down if you don't use it to a certain degree in an ambulatory manner.
It just shows how critical to the normal health and well-being of an individual is a healthy musculoskeletal system. So having technology that allows us to intervene when people are having trouble is so critical to maintaining the overall health of our community. And that's why both you and I, we've seen over the years how important what we do is to our various patients.
And it is a public health problem. This is not a rare disease that a handful of people have, and this is like your grandma, your friend, your neighbor.
These are the most common problems in our community, and as I said, the vast majority of people have it within themselves if they're an adult.
Now, about 1.6 million spinal fusions are performed last year in the United States, and considering that we are getting our population is getting older, the musculoskeletal, including spine, is going to have more prevalence in our society. And there is a good indication that if we don't do something different, we are going to break the bank. Like if we start keeping all these patients 7 days instead of one night, if we can do only one surgery versus 5 surgeries we are going to break the bank. In that sense, maybe it's an appeal to my colleagues and to this community. Start looking at the data, because that's all I'm asking for. I'm not asking them to just jump on the bandwagon, but the public give us literally an obligation to look over the data. You know, sometimes what I hear from my colleagues, that they don't have time to look over the data. When I present them the data, they say they don't have time to look into that. And I think that's the betrayal of public trust. If we are presented with evidence, we refuse to look over them. I think that is unbecoming of our field of what we call ourselves academic. So this has been tremendous. Do you have any closing comments?
Well,
Colin?
I wish upon you great success in the continued development of this technology. It's a process. It's been an interesting one to see over the last decade. I'm sure the next decade is going to be even more fascinating as this gets more and more refined. I really hope that the other people involved in the decision making and or training of individuals will lighten up and learn that this is a change in how things are being done, but it's a very beneficial one.
No, I thank you so much, and I always have counted on your support in this. I think one of the best way to come out to the conclusion, your personal experience with that. If somebody asks you about what kind of surgery should they get, open surgery or olive or procedure or open and so on, what would you tell them? Like family member, friends, and so on. What would you tell them if they are in the process of making that decision? Now, my recommendation for them is, first of all, get multiple opinion and go make yourself knowledgeable about that. If a surgeon trying to make sure that you are not in the capacity to understand that, that is a bad sign, because I think any good surgeon can explain to you things the way you understand. But if somebody comes and asks you, Colin, I have bad problem, I'm offered surgery this way and that way and so on, what would be your recommendation to them?
Well, I know what it is because I do it on a daily basis now,
Yeah.
where I am making the recommendation for these people, excuse me, to at least come and have a consultation with you to determine, is this an appropriate technology for you? And I know that within your own group, that the vast majority of people, 80%, I believe, are seen and consulted, and you don't do surgery on them. You're finding other techniques that are even simpler to help relieve their discomfort. So I know that you're not a knife happy surgeon, and I know that when it is applied appropriately, this technology works very well. So I'm very comfortable recommending that they at least go to the stage of having a consultation to determine what's right. But when they have to ask themselves, when I get that consult, does the person I'm talking to understand the full spectrum of options? As of right now, many of the surgeons out there don't understand all of the possible choices. And so you have to be really careful about who you're talking to when you're getting that consultation. They need to be somebody who does see the choices that are available.
Yes, and I think I can totally agree with that. Make yourself knowledgeable, and there's a lot you can find out about your surgeon and your surgery today, and there's enough data that as well make the knowledge available to a layperson. I think we all have an intellectual capacity to understand, not maybe in every detail, but the great concept of the surgery. And at the end of the day, I'm happy to be educated as I know you are.
My last advice for anybody who's looking for a consultation on something like this: do not leave a visit with your doctor without a clear understanding of what they think is wrong with you and what they think the options are for managing it. I see too many people who ask them what was wrong, and then they go, I don't know. That's not a good way to leave a consult. You should, it's up to the doctor to educate you so that you feel comfortable, that you know what's wrong. Please, 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 particularly when it comes to something as major as a back operation, be certain that you've challenged the surgeon to educate you so that you know exactly what they think is wrong and exactly what they think should be done with you.
Well, it has been a tremendous privilege to have you here, Colin, and thank you for joining me in this podcast, Essence of Medicine, the Evolution of Technology in Musculoskeletal Surgery. For everybody who's going to see that, please return. We have a weekly podcast about Essence of Medicine where we explain medical the technology, medical situation, medical kind of problems, and yeah, for my group here in the IS Live, and for my guests. Thank you for joining us.
Thank you for having me.
Thank you.